The second mini lecture will focus on the use of telaprevir and boceprevir in patients with HIV and hepatitis C genotype 1 co-infection. At the time of the development of this module, telaprevir and boceprevir have not been approved for use in patients with HIV infection, so the use of these drugs in this population would be considered off-label. It is important to consider the use of these drugs in HIV-infected patients, since hepatitis C is a common comorbidity in this population. 1/3 of people living with HIV in the United States are also infected with hepatitis C. Cohort studies have shown that HCV is a leading cause, if not the leading cause, of non-AIDS-related death in HIV-infected persons in the developed world. The cause of death observed in the DAD cohort study are shown here. 13.7% of deaths were attributed to liver-related disease, and the vast majority of these were due to hepatitis C infection. Data about the use of boceprevir and telaprevir has been presented from small studies of boceprevir and telaprevir in HIV Hep C treatment-naive co-infected patients. Similar to the study in naive mono-infected patients, telaprevir improves SVR by approximately 30%. The on-treatment response in SVR is shown here in blue. In light blue, the SVR from the advanced study of mono-infection is shown for comparison. ARVs allowed in this study included atazanavir-ritonavir, efavirenz, and no antiretrovirals. Response-guided therapy was not used, so all subjects were assigned to 48 weeks of treatment. Response-guided therapy is being used in the ongoing phase 3 study, and prior non-responders are also being studied. Results of the use of boceprevir-based treatment in HIV hepatitis C genotype 1 treatment-naive patients has also been presented. Again, a greater than 30% improvement in response with the addition of boceprevir to peginterferon and ribavirin was observed, as shown in blue. Again, in light blue is the SVR rate observed in the mono-infection study for comparison. Importantly, efavirenz-based regimens were excluded in this study, but protease inhibitors were not. Note, the FDA subsequently came out with a recommendation to not use HIV protease inhibitors with boceprevir because of concern of drug interactions, after reviewing results of PK studies in healthy volunteers. Response-guided therapy was not studied, nor were prior non-responders. Both are being studied in ongoing clinical trials. An intense PK sub-study of boceprevir with HIV protease inhibitors and efavirenz is also being conducted. In general, there were no surprises in terms of side effects in HIV-infected patients, as they were similar to that seen in mono-infection. The side effects that were observed greater than 10% more frequently with the addition of protease inhibitors are shown here. As mentioned earlier, significant interactions between boceprevir and telaprevir and HIV protease inhibitors and efavirenz were observed in healthy volunteer studies. Boosted atazanavir and efavirenz were allowed in the telaprevir phase 2 study. The telaprevir dose was increased with the concomitant use of efavirenz. Comparable telaprevir levels were observed across the 3 groups. For boceprevir, the phase 2 study did allow protease inhibitor-based antiretroviral regimens. Atazanavir-ritonavir was used more than lopinavir-ritonavir or darunavir-ritonavir. Despite the drug interactions observed in healthy volunteers, in the phase 2 treatment study, there was no difference in the HCV response by antiretroviral group and no increase in viral breakthrough. The New York, New Jersey AATC website has a useful quick guide describing the interaction between boceprevir and telaprevir and the antiretrovirals. The DHHS guidelines for the use of antiretrovirals in adults and adolescents provides helpful guidance about initiating hepatitis C treatment regimens in patients who are receiving antiretrovirals, given the known PK interactions. However, these recommendations are limited to patients on boosted atazanavir, raltegravir, and efavirenz-based regimens. For others, it is recommended to consider treatment through a clinical trial until further information is known about drug interactions. Thus, it is important when treating co-infected patients to know what you don't know. At the time of the creation of this module, no data exists regarding response-guided therapy with boceprevir or telaprevir for co-infected patients. Response rates in advanced fibrosis and cirrhosis are also not known. Questions remain about drug interactions and optimal dosing of these drugs. I showed encouraging data about tolerability, but from studies of rather small sample size. Implications of resistance remain to be determined. So choosing whether or not to treat a patient with boceprevir or telaprevir-based hepatitis C treatment regimen now or waiting for other agents in the pipeline must be an individualized decision that takes into account many factors, including but not limited to those shown in this slide. Factors that support treatment sooner include advanced but not compensated liver disease, cryoglobulinemia or other side effects, favorable predictors of response, and patient preference. Acute hepatitis C has high response rates to peg interferon and ribavirin alone, even for genotype 1, but some patients may benefit from the addition of a protease inhibitor. However, it may be necessary to wait for interferon-free strategies in patients who are interferon unwilling, intolerant, or have a contraindication such as drug interactions. For these patients, the best option may be deferring treatment until there are newer agents or a better understanding of the pharmacokinetic interactions. The option of a well-designed clinical trial should also be considered. Patients who are not treated should be evaluated and monitored. Appropriate interventions to reduce the progression of liver disease should be offered. Now you can apply what you learned in this lecture to a patient case focused on drug interactions.